Hello, my name is Ravi Vij. I'm from My Cancer Haven, and today I have with me Dr. Anand Patel, who's Assistant Professor of Medicine and Medical Director of the Inpatient Leukemia Service at the University of Chicago, one of the premier heme malignancy programs in the country here, to talk to us about how I treat newly diagnosed adult acute lymphoblastic leukemia. Welcome, Anand.
Hi, Ravi. Thanks so much for having me, and really excited to be able to discuss this topic with you today.
I appreciate it. So, just to lay the background before we launch into the management, can you give us a little idea of how big a problem this is and who gets acute lymphoblastic leukemia?
Yeah, absolutely. So, acute lymphoblastic leukemia, or ALL, is a rare disease. There are about 6,500 diagnoses a year, and the majority are in children. That being said, in centers where there's expertise in the management of acute leukemias, oftentimes adults who have ALL are referred to those centers for management. So you do have adults that are kind of in this adolescent young adult population, 18 to 39-year-olds, and then a second peak that happens in those that are over the age of 50.
So, as far as the diagnosis goes, how do you diagnose it?
Yes. So many times the first tip-off will be abnormal blood counts. So you may have blood counts that are high, such as a white blood cell count, or blood counts that are low, like the hemoglobin or the platelets. Patients can also have lymphadenopathy, meaning enlarged lymph nodes, sometimes the neck and the armpits. And they can have very non-specific symptoms, just feeling not right, feeling really worn down, tired. And that's typically what sets off the workup to try and arrive at a diagnosis. Now, typically, the diagnosis is confirmed by performing a biopsy, and that could be either a bone marrow biopsy, or if there is an enlarged lymph node, possibly a lymph node biopsy. There are some occasions where the diagnosis can be highly suspected or even confirmed based on studies from the blood alone, if there is a high enough number of leukemia cells that are present in the blood.
So I understand that you also have to do a few other tests, as you have done here, shown us here in your slides. Sometimes a lumbar puncture and.
That is correct. So acute lymphoblastic leukemia is a disease of the bone marrow, but there are other sites that can be involved. So for example, many patients who have a subtype of ALL called T-cell ALL may have a mediastinal mass, which is a mass kind of in the chest area behind our rib cage. And many patients, about 10% of patients or so, can have involvement of the spinal fluid that protects our central nervous system, what we refer to as the cerebrospinal fluid, or CSF. And typically a procedure called a lumbar puncture or spinal tap is needed to assess and see if there is in fact leukemia in the spinal fluid.
So I guess broadly, how do you segment the ALL population? We'll get into the management of these individual types, but how do you approach this whole area?
Yeah, and I will say this is a field that has changed significantly in the last 5 to 10 years. So we have several therapies that we'll get into that have really revolutionized how we think about the management of ALL. But I like to think of, after the diagnosis is made, there are a couple different branch points. The first branch point is if the disease has a abnormality in the chromosomes called the Philadelphia chromosome. So what we refer to that as Ph positive ALL or Philadelphia chromosome positive ALL. This subtype of ALL really has its own specific management and treatments that are available. So I like to kind of think of it as its own disease within a disease. It really should be kind of thought of as separately from those that don't have this Philadelphia chromosome, which we refer to as Ph negative ALL. So Ph negative ALL can be either B-cell ALL or T-cell ALL, and that refers to the lymphoblasts or cancer cells and what type of lymphoid cells they are. The next branch point is whether a patient falls within that AYA or adolescent young adult age group, or if they are older than that age group. And typically the cutoff we use is around 40 years old. The reason this matters is because as adults develop ALL, many of the treatment decisions we make are borrowed from our pediatric colleagues. So those patients that fall within this AYA age range we may think more strongly about using the same sorts of drugs that we would use for a pediatric patient. Those that are older than the AYA age range, we may have to slightly modify the treatment approach to allow for both effective treatment of the leukemia without significant side effects.
So obviously, this is a complex area, and we'll try to simplify it as far as possible. But as far as the treatment goes, I understand that in contrast to some other leukemias, the treatment of acute lymphoblastic leukemia can be fairly protracted. So can you give us a flavor for how a patient who has been diagnosed with, first we'll just talk about ALL, and then we'll get into the nuances of the AYA and the adult and older individuals also with ALL, but how overall do you approach the treatment paradigm?
Yeah, that's a great question. And really, it's very helpful when thinking about ALL to break it up in phases, just like what's done here. So typically, the first treatment strategy that is used for someone's ALL is used with the goal of getting the disease into what we call a remission and trying to do it fairly quickly over the course of 30 days or so. And that regimen, that first kind of treatment plan that is given is typically called induction chemotherapy. Oftentimes, this will involve several different chemotherapy drugs, plus there will be lumbar punctures that are done, and the frequency of those lumbar punctures will depend on if there was disease found in that spinal fluid at diagnosis or not. Once patients achieve a remission, they typically are transitioned to what's called consolidation therapy. And consolidation therapy can vary greatly from one treatment regimen to the next, but the overall goal is to deepen the remission that we are hopefully achieving after induction therapy. Then we get to maintenance therapy, and maintenance therapy can be anywhere from a year to even 3 years, depending on the regimen that is used. Now, maintenance therapy typically is comprised of several different drugs. That being said, most of it can be done in the clinic or as an outpatient. So really, the goal being to continue on therapy, but not have it disrupt your day-to-day life outside of needing to come to clinic at scheduled visits. Now, in parallel with all of this, we carefully consider and think about if ultimately we think someone needs a stem cell transplant to achieve a cure for their leukemia. And typically, the type of stem cell transplant we use is called an allogeneic transplant, meaning cells coming from someone else, a donor. And many times we don't know right at the outset when someone is diagnosed if they will ultimately need a transplant or not. Much of that decision-making centers around how quickly a remission is achieved and if we can detect leukemia with very, very sensitive testing that can find even 1 in 10,000 leukemia cells or 1 in 1 million leukemia cells. And this is the concept of MRD, or measurable residual disease. So not all patients with ALL need a transplant for cure, but we are almost always at least thinking about if transplant will be necessary for cure.
So you've given us a broad flavor for these various treatment phases, and you mentioned that maintenance therapy can be given as an outpatient. What about the initial phase of treatment, like induction therapy? How aggressive is that, and the consolidation phase?
Yeah, that's a great question. So typically, patients who have a new diagnosis of ALL begin their treatment in the hospital. And there's a few different reasons for that. When patients are first diagnosed, that's when the amount of leukemia in their body is at its highest. So as we start treatment and as those leukemia cells begin to die off, there is the risk of electrolyte abnormalities or irritation to organs such as the kidneys. So we want to be able to monitor that on a daily basis. The other thing is many times blood counts are low when treatment is started because the bone marrow is full of leukemia instead of healthy cells. So patients may need frequent blood transfusions. In general, I would say patients are admitted in the hospital for somewhere in the neighborhood of 2 to 4 weeks during the induction therapy. From consolidation therapy onwards, the goal is really to be able to administer as much therapy as possible in the clinic or in the outpatient setting, recognizing that there may be complications that then require admission. So a good example, for example, would be as if you develop a fever when you're in the midst of treatment, and if your blood counts are low, we would recommend being admitted to start antibiotics and look for a cause of that fever, such as an infection.
So obviously, there are a number of different drugs that we have in our armamentarium, and you mentioned that the paradigm for AYA and non-AYA adult differs. So how does it differ? What is the difference in approach, and why so?
Yes. So AYAs, as a reminder, adolescent young adults, we typically will utilize what we refer to as pediatric-inspired regimens, meaning we will use many of the same drugs and combinations of drugs that we use in pediatric patients in ALL. And my colleague, Dr. Wendy Stock here at the University of Chicago, and others have really done lots of work to show that when you use pediatric regimens in this AYA adult population, the outcomes are much better compared to kind of traditional adult chemotherapy approaches. The drugs that are very important in the management of ALL when thinking about a pediatric regimen include steroids, and there's a few different steroids that can be used. One is called prednisone, the other is called dexamethasone, and the other big one is a drug called asparaginase. And asparaginase is a medicine that depletes the vital building blocks that leukemia cells need to grow. However, asparaginase does have toxicities that are associated with it. It can irritate the pancreas. It can cause blood clots. It can irritate organs like the liver. And what we have found is you really have to have a level of comfort with asparaginase to be able to use it safely in the AYA population. But ultimately, the inclusion of asparaginase and steroids is vital when thinking about using a pediatric-inspired regimen. Now, there are other drugs that are part of the regimen, such as those that are listed in bullet point 3, these chemotherapy drugs. Now, when thinking about the AYA population, pediatric-inspired regimens are typically what we reach for. In patients that are older than 40 years old, I would say the treatment regimen we reach for can really vary from treating physician to treating physician and what other medical conditions a patient may have. We many times will use a pediatric regimen even for our older adults with ALL, but we will significantly reduce the dose of asparaginase to try and limit any side effects from asparaginase. Other groups will use more traditional chemotherapy without the inclusion of asparaginase, and a very common regimen is one called hyper-CVAD, which uses a regimen of different chemotherapeutics that are alternated from one cycle to the next. Now, the other thing that has really impacted the management of treatment in B-cell ALL specifically is we have several what I would call antibody-based drugs or targeted drugs. And three of them are blinatumomab, which targets CD19, which is on the cells of our surface of leukemia cells, inotuzumab, which targets CD22, and rituximab, which targets CD20. Blinatumomab and inotuzumab are currently approved for relapsed refractory ALL, meaning ALL that's previously received treatment. And blinatumomab can also be used in those that have low level of detectable disease or MRD positive disease. However, there are several studies that are ongoing to try and establish the benefit of using these medicines earlier on in treatment, perhaps with the goal of reducing the amount of traditional chemotherapy and keeping the effectiveness of our regimens intact while reducing the toxicity. There is a similar concept underway with T-cell ALL using a drug called nelarabine. So nelarabine is approved for relapse refractory T-cell ALL, and in studies looking at children and young adults with ALL, nelarabine has been incorporated into a pediatric regimen. And it does seem that when you incorporate it, the rates of someone's disease coming back are somewhat lowered. So there is potentially a role for nelarabine being incorporated. I will say right now, nelarabine, blinatumomab, and inotuzumab, again, are approved in the relapse refractory setting. But as the evidence base for them increases in using them earlier on in a new diagnosis, that may change in terms of our standard of care.
So, yeah, what about the very old? I obviously that is a very subjective, statement. But suppose a patient is frail in their late 70s, 80s. Do you make any modification to their treatment? How do you approach that?
Yes, absolutely. That's a great question. So in patients who are, 65 or older and are maybe a more frail, have other medical conditions, we really think about significant adjustments to the chemotherapeutics that are given. So a good example is there's this chemotherapy regimen called hyper CVAD. There is a counterpart to it called mini hyper CVD. So the doses are given at a slightly more tolerable level. And there are lots of studies going on looking at, can we use this backbone of lower dose chemotherapy and then include highly effective medicines such as inotuzumab in conjunction with those to preserve the efficacy while making it more tolerable. Another drug that's been investigated in ALL is one called venetoclax. And venetoclax is a drug that's approved for a number of different blood cancers, such as chronic lymphocytic leukemia or acute myeloid leukemia. But there has been increasing evidence to show that it's highly effective in the treatment of ALL as well. And therefore, there are studies ongoing that look at lower dose chemotherapy and adding this oral pill venetoclax on top of that.
And you had mentioned at the outset that Philadelphia chromosome ALL is a disease within a disease. So, how do you tackle this uh, entity, and how frequent is this among your adult patients?
Yes. So Philadelphia chromosome positive ALL has gone from, in the late 2000s, we thought of it as being a very difficult to treat subset of ALL. And now in 2024, it's become a subset of ALL that has amongst the best outcomes in adults. And the reason for that is because this abnormality seen, this Philadelphia chromosome, is uniquely susceptible to targeting with a class of drugs called tyrosine kinase inhibitors. So there's the first generation drug, imatinib, which is used much more frequently in a slightly different blood cancer called CML that also has this PH chromosome. And then there's several other tyrosine kinase inhibitors, nilotinib, dasatinib, and ponatinib, that have been incorporated into the initial treatment of Ph positive ALL. So the frequency of Ph positive ALL increases as patients get older. So if you have a patient above the age of 60 or so with a new diagnosis of ALL, it's about a 50-50 shot as to whether they will have Ph positive ALL or Ph negative ALL. And right now, there are a number of different backbones to which these tyrosine kinase inhibitors are added to. So we know that while these drugs are quite effective, using them by themselves in Ph positive ALL does not seem to allow for durable responses, meaning a remission that lasts for hopefully years and years. So there have been studies that have looked at the combination of these regimens with chemotherapies, such as methotrexate, and other drugs that we use for more of our pediatric regimens. There's also been studies that have looked at the inclusion of these drugs, these tyrosine kinase inhibitors, with the antibody-based therapy blinatumomab. And there's very promising data to show that potentially patients with Ph positive ALL can be treated with tyrosine kinase inhibitors plus antibody-based therapy and may not ultimately need chemotherapy. The major caveat I will add is those studies are very premature. We've only been able to follow patients for a couple of years on those studies. And really, what we're interested in seeing is how are patients doing, 5 years out, 10 years out, maybe even beyond, to really get a sense of not just how effective these sorts of regimens are, but how durable these regimens are.
So you said that this used to be one of those leukemias that we thought of as having a poor prognosis. And I remember when all we tried to do was try to get these patients to a stem cell transplant as soon as possible. In your practice, what is the role of a stem cell transplant nowadays for patients with Philadelphia positive ALL?
Yes, and I will say this is an area of controversy even today. At our institution, our practice is if patients with Ph positive ALL achieve a remission and even with our very sensitive testing, do not have any detectable disease, we tend to complete a treatment with a tyrosine kinase inhibitor plus additional therapy, whether it be chemotherapy, blinatumomab, or we have a clinical trial looking at the drug inotuzumab, and then we maintain them on their tyrosine kinase inhibitor for several years. Now, one of the things that remains to be seen is how do patients fare if they are on a tyrosine kinase inhibitor for, say, 10, 15, or 20 years, and what side effects may that have? So some institutions may think that if they happen to have a younger patient with Ph-positive ALL, maybe that's a patient that would benefit from a transplant, even if they were to achieve what we call an MRD negative remission, really with the intent of, can a patient stay on a tyrosine kinase inhibitor for potentially decades and have their disease remain well controlled and not develop any side effects from being on a therapy for that long?
So I think that you mentioned some of this in the early part of your talk on the importance of having in the induction phase patients in the hospital. So what are the kinds of supportive care measures you take during that more intensive phase of treatment?
Yes. So during the induction phase, we tend to think of the three types of organisms that can make people sick and cause infection. So you have bacteria, which we typically treat with antibiotics or antimicrobials, and patients will oftentimes be on a preventative antibiotic. You have viral infections or viruses, which we typically cover for with antivirals, and acyclovir is the most common one that we use. And then, especially in the initial phase of treatment, patients could be at risk of fungal infections. So we do have several different antifungal medicines that can be used. One thing that has to be carefully thought about is antifungal medicines can interact with chemotherapy drugs. So sometimes the antifungal that we choose is dependent on what chemotherapy regimen is being used to avoid those interactions. Almost all patients with ALL will also develop low blood counts to the point where they need a transfusion at some point or another. So I would say receiving transfusions during that intensive or induction part of regimen should almost be considered an expected part of treatment.
So you mentioned at the beginning something about having to give lumbar punctures for patients. So this is something that continues through various phases of treatment. Like, could you give us a little more insight into how protracted this phase of treatment is?
Yes. So how many lumbar punctures a patient should get is dependent on if there is disease, and by disease I mean leukemia cells, present in the spinal fluid or not. So about 5 to 10% of patients who have ALL will also have involvement of their spinal fluid at the beginning of their treatment. And typically what will happen is during the initial part of treatment, lumbar punctures may be even done on a weekly basis to clear the spinal fluid. So when a lumbar puncture is done, we do two things. We give a small dose of chemotherapy. We also collect a small amount of fluid to look at under the microscope and make sure those leukemia cells are going away. And then even for patients who don't have involvement of their spinal fluid, we typically recommend that they get at least 12 lumbar punctures during their entire treatment course. So these can be spread out, and you may get, one lumbar puncture a month at first, and then it may become more like once every couple months. But we do know that just because there is not leukemia in the spinal fluid at the beginning does not mean that the lumbar punctures should be avoided, because the spinal fluid is a place where leukemia cells like to hide, and chemotherapy given through the IV or by mouth may not penetrate that spinal fluid, which is why we need to give chemotherapy directly into the spinal fluid. But in general, depending on where you're getting your treatment, 8 to 12 lumbar punctures is kind of the magic number that we aim for to give spinal fluid.
And so once your patient has gone into a remission, how do you monitor the patient? Are you doing blood tests? Are you doing periodic bone marrow biopsies? How are you seeing that their disease is remaining in a remission?
Yes, and I love the figure that's on the right of this slide, because I think it really nicely illustrates that you can only know how much leukemia is present if you look deep enough. So typically, a bone marrow biopsy will be done at diagnosis to make your diagnosis. We will typically get a bone marrow biopsy at the end of induction to confirm that a remission is achieved. And when I say remission, I mean less than 5% leukemia cells. But we also know that just looking under the microscope is not enough to characterize if there is leukemia present or not. We've developed tests that capture MRD, or measurable residual disease. Two of the most common tests, one is called flow cytometry, which can capture 1 in 10,000 leukemia cells. There's also what we call next generation based MRD testing, which can capture 1 in 1 million leukemia cells. And usually our practice is we would do bone marrows kind of after each cycle of treatment for as long as there's still MRD that is detectable. Once the MRD becomes negative, we'll have a conversation with the patient about if they would prefer us to monitor the disease from blood alone, or if we would still be getting regular bone marrow biopsies. And I would say historically, frequent bone marrow biopsies have kind of been a standard in the management of the treatment of ALL. But as these tests become better and better at detecting disease even in the blood, we may be able to find a happy medium where only the essential bone marrow biopsies are the ones that are performed, with much of the other monitoring potentially happening from the blood.
So during the maintenance phase, which you said could extend out to even 3 years, are you following MRD routinely? And if so, is it for periodic bone marrow biopsies, or are you doing some MRD tests on the blood?
Yeah, so historically, these MRD tests, I would say, have become much more prevalent in the use in clinical use for ALL, probably in the last 5 years or so, particularly when being able to send them from the blood. So when patients are in the maintenance phase, typically we will not do regular bone marrow biopsies as long as their blood counts are kind of staying in a level that would be expected, and we will intermittently monitor to see if there is disease detectable in the blood with MRD testing. And that can be anywhere from every 3 months to every 6 months in terms of when that is sent or when that is looked for.
So obviously, this is a disease that in pediatrics, at least, is very highly curable. And how are we doing in our adult population?
Yes. So I want to use kind of that same breakdown of AYA patients and then patients that are older than that age, because we still have some work to do in terms of making sure that outcomes are equally excellent for everyone. So with pediatric regimens in the AYA population, our cure rate is somewhere in the neighborhood of 70 to 75%. And now that we have very effective regimens for use in patients whose disease has returned, like inotuzumab and blinatumomab, even if those patients may not be cured with their first type of treatment, potentially we can get them back into a remission, take them to transplant, and try to cure them there. Now, when you get above that kind of age of 40 or so, historical outcomes have been quite poor. So long-term overall survival could have range anywhere from about 20 to 40%. But I'd say that number is rapidly improving. So as I mentioned, we have several different clinical trials that have been ongoing or recently reported that are looking at less intensive chemotherapy combined with highly effective targeting drugs. And while we need longer follow-up, we need to be able to follow patients for longer and longer that have been treated on these studies. We are getting to a point where the vast majority of patients with ALL achieve a remission, no matter what their age is. And then the question becomes, how do we maintain or keep them in that remission?
So obviously, this is an area where even in adults, progress continues, and your institution has been doing some of the key research in this area. So where do you see the field moving? I understand one of the trends you mentioned is moving away from chemotherapy if possible and going to non-chemotherapeutic approaches, and the other seems to be MRD. Any other trends that you see in the next few years that will impact the outcome of these patients?
Yeah, absolutely. And, I think the other exciting therapy in the management of ALL is CAR T cell therapy. So right now, there are two approved CAR T-cell therapies for ALL. One is for patients that are pediatric up to the age of 25. And the other CAR T-cell therapy is approved for all adults with B-cell ALL. And as of right now, the standard use of those is when the disease has returned or has not gone into a remission. However, I think there is interest for patients who have very high risk disease, whether using CAR T cell earlier may allow for cure without proceeding to a stem cell transplant. And I think better and better understanding of which patients would benefit from a stem cell transplant because of how high risk their disease is versus which patients don't need a transplant if they achieve MRD negativity will be kind of an essential part of how our care moves forward in the management of ALL. So I think in my mind, there's kind of three buckets, two of which you had mentioned. The first bucket is use of less toxic treatment that is just as effective, use of better and better MRD techniques to capture if disease is not responding as expected, and the third one being who benefits most from stem cell transplant, particularly when their disease is in a remission for the first time.
Well, thank you very much for that excellent overview about the treatment of the frontline, newly diagnosed adult ALL patient. Hopefully, I can have you back for another absorbing session on another topic in malignant hematology.
Yeah, I would love to be a part of this. And again, thank you so much for the invitation, and really very happy to be part of the My Cancer Haven family at this point.
Thank you very much. Appreciate it.